Welcome, Tim.
Hi, and thank you very much for inviting me, Henry. I'm very pleased to be here.
I'm like crazy level thrilled. Like it's your, yeah. I mean, you are an extraordinary person who's had an extraordinary career and continues to, with insights into ADHD and the NHS that no one else has. And you're closing out our global conference, which is, as I think you've just heard, kindly waiting in the wings. We've been live for 28 hours with ADHD Australia taking over for our night. We've had extraordinary speakers from Lisa just now, who talking from lived experience in the heart on ADHD and autism. We've had celebrities like Sam Thompson. We've had entrepreneurs like Ben Branson. The list goes on. So it's been wonderful, and you are signing us out, which I'm very, very excited. So this is an in conversation section. We are talking together, it's which is the point at which I'm supposed to find the questions very smoothly, and I'm getting slightly tripped up. Exciting. Do you want to tell me, like, what does it mean to be the National Clinical Director for Mental Health at NHS England? Because I know how serious the role is, but others might not.
Broadly, you've got two main jobs. One is that you run a program, that you're the clinical director for a program of work. So, for example, perinatal mental health or community mental health teams or whatever. And your job is to help roll those out across the country. And that sounds terribly easy, but actually scaling up is complicated, extremely complicated. And it's often very difficult to know whether you'll be able to actually reliably take an innovation and spread it around the country, and it's still doing the same thing that you started off doing. So that's one half. The other half is that you spend the time advising ministers, mainly in the Department of Health, but you are also expected to provide advice across different government departments. So that might include the Home Office around terrorism and mental health or whatever. It might be number 10. It might be areas like the Foreign Office when you're running a global ministerial summit, or it could be housing and so on. So it's a job which basically don't do it unless you're willing to work 24/7. And I'm very relieved not to be working 24/7 anymore.
Although I think it's been a busy period because you've just come back from a global summit.
I have. I set up the Global Ministerial Summit on Mental Health in 2018, and we brought over about 50 odd countries from around the world came to the summit, including 25 ministerial delegations from all over. And we actually flew over 200 people with lived experience from all over the world. So it was really important that we had such a strong emphasis on bringing people with lived experience and the politicians there. And the whole thing culminated in a meeting which I sort of engineered, and in bringing all the people with lived experience to tell them the recommendations from the global summit, from all the work that happened in 2 days, to tell the politicians what they needed to do. And I can tell you, politicians listen far more to people with lived experience than they do to academics.
We sometimes feel like it's the other way around, but
I know. I think health services.
I think it's together. It's the combo deal that works. Like data and evidence, lived experience for heart, and you obviously brought those two together. You've stopped doing that. What are you doing now?
Well, I'm now national clinical lead for new models of mental health care. So I'm overseeing a set of pilots that will radically change the way that we deliver mental health care. And I think the bit that is really important for this summit, this conference, is that we are aiming for these pilots to be open 24/7 in the middle of their neighbourhood of about 40,000 people, and it wouldn't say no to people. So yeah,
Wow.
we've had questions. Would you treat people with ADHD? Well, the answer is yes, I would, and I do.
I think one of the hardest aspects right now in terms of mental health care provision is the lack of places to go when there's a crisis. And so
Yeah,
we get people contacting us and, in crisis or actually pre-crisis where
yeah.
there's just nowhere. Like you're just until and that is a so to hear that kind of plan is coming is a genuinely wonderful thing.
Well,
There's a huge
think,
gap.
fingers crossed that this will be scaled up, and that's always
Yeah,
the
no, fair enough. Yeah,
uh, at the moment the government don't appear to have a whole lot of money, and scaling up something that I think is important for everyone, because we're not going to say there'll be no wrong door. If you come to the centre from your neighbourhood, we will find some way of working with you, and it's working across with the voluntary sector and with social care, local communities, and the whole thing is co-produced with the local community. So it's always asking the local community, what do you want? What do you need? And each local community is different. So I'm doing that, but I'm also chairing, as I think you know, Care ADHD,
yeah.
which is taking more time. And but as a chair, it's got a very circumscribed role, which is to make sure we deliver high quality, low cost services.
And it's a big deal, right? Like the high quality, the high quality, low price, like is, and working out how to do that, and not being the, and I do want to talk to that because actually we obviously run a lot of support groups. And
Yeah,
I talk to a lot of people, and actually a lot of the time people are like, my local options are closed to me, particularly if you're outside of England without right to choose,
yeah,
and. Uh, I absolutely do direct people to Care ADHD, and I'm going to say the price because I think it's important because one of the things that we see is some really high prices, and not only on the front door, it's when people are then, if they're opting for medication, what that looks like. And
yeah.
I've seen that up to £250 per month just in a consultation fee plus prescription on top. So you're ending up looking at sort of £400 a month, and
Which
it's
is beyond
unaffordable.
a lot of people. A lot of people can't afford that kind of money. I totally agree.
No, and so the Care ADHD prices, which I do believe are like one of the lowest, if not the lowest, is a 399 for the assessment, and yeah, medication initiation is 599. Like it's in a it's an important service, and then you're doing right to choose as well. But
Yeah,
like I think it shows the heart of what you're trying to do, what Care ADHD are doing, like which is this focused quality service, but looking at price to make it as accessible to everyone, recognizing that we have a problem. Some people, the NHS is not there. Like um,
I
and
mean,
there's a
I should say that I mean my reason for joining Care ADHD from the start was very strongly motivated by, apart from personal ones, I've got two of my kids have got ADHD, and it took them a long time to get any service or any help really. And although I'm pretty sure when they got diagnosed. And I have to say, I did probably what the usual parent thing is. But what do you mean they're just like me? You sort of think. So I've got personal reasons, but having done the guideline on it, and having had the chance to really look at what the evidence is. I don't know if you know, but I'm guessing you do know, that actually the evidence behind the treatment in ADHD is really remarkably good.
Yeah.
So much so that actually the use of medication, so methylphenidate and lisdexamfetamine, in children, the effect size is about 3 to 4 times as big as almost all the other psychiatric drugs. So it is an incredibly effective intervention. And again, with children, we've got huge amounts of evidence around parenting programs, around behavioral interventions, about enhancing those interventions by linking up with the school. So when I was approached by Care ADHD, I know both Mark Pattison and Bobby Pratt well. I've worked with Bobby before. I said I would be chair if for two key reasons. One, if we are going for really high quality, nice concordant care, and I can guarantee that, and I would hold them account to that, and that we could demonstrate that we were the lowest cost and a lower cost than the NHS. If we could do both of those, I would be chair. And they both agreed. And it's a great opportunity to do something that I think, I spent 16 years doing NICE guidelines. That's what they are all about. High quality, low cost care. And I think we're proving it can be done. They are a fantastic team, I have to say. But
I've certainly been obviously very impressed by them, having got to know them as well. As I have, onto our questions. I was just struck. So were your children diagnosed before or after you did the ADHD guidelines for NICE?
Oh, after, yeah.
No,
after.
And did you? But when you looked at those, there was no epiphany about you. There was once it was brought home that you recognised.
When I did the guideline, I do remember one of the guideline group members, who's an expert in children. She did come up to me and tapped me on the shoulder and said, I mean, I won't say exactly what she said, but it was very funny. I think she said, "You're so fortunate to be very bright because ADHD doesn't work so well if you're not." And I was completely taken aback. It was she'd obviously been looking up close. I sort of guessed that it was quite likely. I share a lot of similarities with my children who have been diagnosed, so it's not a surprise.
Tell us about doing the guidelines, because it was a bigger deal than I think people know, and people know it was a big deal.
Okay, so when we came up to doing the guidelines, I had long conversations with NICE, because it was a very contentious diagnosis, and there were a lot of people in the press, and in the what I think of as a sort of anti-psychiatric lobby, who were saying this was medicating children in particular, who were basically naughty children, and there was nothing more to it. And so I spoke with NICE and said, I thought it was really important that we looked at the evidence behind the diagnosis. We've never done that in NICE guidance before or since.
Oh, wow.
So we had a whole work stream which I personally oversaw. Now, I didn't chair the guideline. I did what I call facilitated the guideline. I chaired the very first NICE guideline and set out the methods, but we have an independent chair. My job is to lead a research team and to facilitate the guideline group. So I helped them work their way through everything. And I had a research team that did all the work for them. And then I'd help the guideline group understand what that research evidence meant, and then how to make recommendations out of it. So we had a work stream on diagnosis, and when we finally produced the guideline, I could stand up and perfectly happily talk about the reality of that diagnosis, and to the shock of some people, I remember in one interview with the press afterwards, where I was asked, "Well, is it really real? What do you mean? How do you know it's real? What blood test can you do?" And I said, "Well, in diabetes, there is no blood test that proves that you have diabetes, but you can measure blood glucose. And if blood glucose goes above a certain level, we know that that's harmful to people. And in exactly the same way, we can measure people's behavior and experience. And we know that when hyperactivity and impulsivity and inattention reach a certain kind of level, it impairs their function. And they can't, I fail to see how that's different. And I do think that. I think it's one of the things that we can do is we can see what impairments come with those kind of behaviors and experiences. So to go back to your question, Henry, yes, it was a very big deal. It was the biggest deal of any guideline that we've done. So I after we launched it, I spent 3 days continuously in TV studios, radio studios, interviews with journalists from Tokyo all the way over to Los Angeles.
There was worldwide interest.
Absolutely worldwide interest. And we used to produce a hard copy of the full guideline, which is big. Yeah, I mean, it's 1,500 pages. But the guideline, without all the evidence, you could get links to the evidence. But the guideline, 200 and something pages, we had to go to a reprint. We were selling it all over the world. I mean, it was extraordinary. It was the biggest launch we ever had, biggest interests that we ever had. And as I say, the evidence in it is some of the strongest evidence in mental health.
And something to say, so the guidelines, and as you just said, Tim, all of the information is there. Like, you can go to the NICE website, you can go and click into the research, you can go and see what was presented. It's there to be seen, and obviously you've talked about there to back up the recommendations that have been put in place and have changed many people's lives for the better, myself included.
Well, that's great to hear, Henry.
Well, I was actually going to say, yeah, thank you, because honestly, it's right. Must not cry. Most of those interviews weren't so friendly. And a lot of, and why you did all the research and evidenced it was because a lot of people are just like, it's naughty kids, or it's not real. We deal with newspaper articles saying it's just a fashion, it's a fad. Another one saying it's a social contagion. Another just going, it doesn't exist at all. It's just a made up thing. And right now we're in the midst of a big debate. To be honest, we're in the midst of what can only be classed as a culture war in terms of the characterization of ADHD, as we're just trying to lay about, trying to get on benefits, is the framing, pointing to unprecedented demand, linking it to COVID in terms of the demand, We're all at home suddenly navel gazing. What's your view? What's your view on the increased demand? What's your view on the debate?
I don't think there is increased demand, but I could be wrong about that. I know that there's some speculation that entering a world of social media and our connection to the internet, that this is changing us. And I do recognize myself that that when you're bombarded with emails, with messages from all different places, I know that from my point of view, my ability to concentrate goes down and down. Yeah, that I do.
Now I've had this discussion with another, and one of their points was that the big difference is when you withdraw those things, then the situation for them changes. I worry I just took your point away.
No,
Like,
not at all. What I was going to say
was the ADHD jumping in?
what I was going to say was that although I recognise that those being bombarded all the time isn't great for my ability to concentrate and focus my attention, and I'm sure it's not for anyone with ADHD. I'm not sure it's the cause. Yeah, I'm sure it makes things worse. Now, there was a study which no doubt you've seen, which is I think King's College did it, which have made the they've made the assertion that they think that about 5% of the population have ADHD, and that we're not seeing a sudden rise in ADHD. We're actually just seeing more people coming forward, and obviously, with the possibility that you can get help, it's more likely that people will come forward. So certainly I'm not sure. This has happened with a lot of different mental health problems, which is that anxiety and depression and so on, is that more people are on antidepressants than ever before, all this kind of thing. Are we over medicalizing, etc., etc.? I counter that by saying, when I started being National Clinical Director in 2016, our estimates were that we were actually seeing and helping only 1 in 4 children who had a mental health problem. And that we're seeing probably a little bit more than that, but not much more, in adults. And basically, what that meant was that we were saying, oh, we'll only see you if it's very severe. Or, and this is a slightly jokey way of putting it, which is, it's a bit like saying, you drink a quarter of a bottle of vodka a day. Oh, that's okay. Come back when it's 1. Yeah. And you think that's absurd, but that is what's been happening. So it was my job to try and increase the number of kids that we were seeing. And I'm thankful to say that we've nearly reached half of all children that need help are getting help in the NHS. Sadly, and unfortunately, kids with ADHD and autism, that has not happened for them in the same way at all. And equally, I think with adults with ADHD and autism, they are not getting that kind of help, which is what makes right to choose so important.
It does.
So just to summarize that, I don't think there is evidence that this is a bunch of people running around going, look, I don't fancy working, or no, I want some stimulants, or whatever else. I think this is absolutely real. When you meet people with ADHD, as you know just as well as I do, there are some tragic stories, and it leads to, untreated, leads to an awful lot of difficulty. And conversely, I remember doing a radio program when we launched it. It was a phone in, and this mother phoned in and said that her son, who was 5, who she thought was very bright but couldn't couldn't be sure. He didn't read, he didn't write, he couldn't really sit still in class or anything. They were thinking of excluding him. She got him help privately. He got an assessment. He was put on some medication, and within 6 months, he was reading, he was writing. Yeah, he was able to stay in the classroom.
Yeah.
And you just think, yeah, that is a kid who could have been excluded from school at the age of 5 or 6, and you think this is perfectly real.
Yeah, and how many? Yeah, and how many more? Like, the numbers we're missing. And in terms of overdiagnosis, it's like there's a big study done, and it looked at 9 million GP records. It was published in January of this year, and it showed 0.32% of those had a record of having ADHD, which is nudging 10%, if that, of the actual population of people with ADHD. And
Yeah.
so we're wildly underdiagnosed. If we think about things like PTSD, PTSD was first recognized, like, you're going to correct me if I've got this wrong, first recognized, I think, in 1980, and formalized within the NHS in the 1990s. Like, we wouldn't be shocked if we saw PTSD rates increasing because we just didn't recognize it before. And that's exactly the situation we've got here. You're just like, it's a farcical piece of evidence. Say, oh, numbers are going up. You're like, well, of course they are. It's because we didn't count before.
Absolutely. I mean, it's a little bit like, I remember when we did work on children that following abuse and traumatic experiences, recognizing that many of those kids had PTSD and that you really had to ask about it. You shouldn't just leave it. And, since then, people have begun to recognize that that's, big surprise. Of course, they've got PTSD. I mean, that's what happens to most of us when you go through very, very traumatic experiences. I think that it's a similar problem across mental health, that we fail to recognize that experiences like anxiety and depression and post-traumatic stress and so on, ADHD and autism, that these things actually impair people's lives, that you fail to function, and it's associated with significant levels of distress, just as it is with physical health problems. And we recognize that little by little, more and more. And I think ADHD in particular and autism are behind the curve of the rest of mental health. It's being seriously under-recognized, and people, like you say, are resistant. They think,
when you have people saying it's not serious, like, what do you say to them?
Well, I usually give the example of diabetes. You can measure this perfectly easily, and there is no test for diabetes, so you're left to measurement, and you can measure the level of impairment. And when you reach a level of hyperactivity or inattention or impulsivity that causes impairment or distress, you know that it's perfectly reasonable to have treatment strategies that will help. And you do the same in any physical health problem as well.
It is immense frustration where we see and understand that the importance of a diagnosis, the enlightenment it gives through the knowledge it gives, the benefit many find from medication, and that's being stopped. We see high suicide rates.
Absolutely, and which I agree. It's not just the ADHD that's helped; it's the corollaries. It's the I know a lot of people with ADHD who get quite anxious, who get quite depressed, who go out
particularly undiagnosed, right? You're trying to work out life, and
yeah,
and it's extraordinarily different and difficult.
Yeah.
We've seen the figures around life expectancy too. Again, that same study of 9 million GP records showing a significant reduction in life. I think between 4.5 and 11 years less for women. It's for men it's 7 years less. For women it's 9 years less on average. Like, it's a huge difference in that corollary to physical health that we are seeing. Absolutely seeing. I did the to just compare. I went and looked up like what is the life reduction for smoking, and it's about, I think it's 11 years, isn't it? So it's not like we're nudging the same sort of numbers and getting absolutely none of the attention, and especially when yeah, obviously got these treatment options. We're seeing the government just sort of talk to ADHD as like it's a problem, seeing all of the expense of an assessment and intervention, and none of the benefits. Like, what do you say to that?
I think it's up to us collectively, people with lived experience and professionals, to just push to one side all this negative stuff about, well, is it real, isn't it not real, etc., and say, we have a sizable number of people who have significant impairment, significant levels of distress, significant negative impact on their lives, often getting worse the longer this goes on.
Yeah.
And we have some really good treatment strategies that can help them address that. And it's wrong to stop that happening, in exactly the same way as it's wrong to deny people anti-cancer treatments.
And
these work. That's the point, is that we've got really good evidence that these interventions work.
We do. Like, I obviously know in my own life, like, and when the people I talk to, and it's only a frustration for me that we're talking about millions of people. Like,
Yeah.
I think the NHS task force came up with a number of around 3 million, and I think that's England alone. Like, and you're looking at things like increased exclusions from schools, likely to be in pupil referral units, increased percentage of victim of crime, in like being in crime, and so a number of the big national problems. We did a talking to an organisation working with NEETs, and their estimate, which is like, I have to caveat very carefully, not academic, very much sort of screening and one person trying to see, but the figures they came back from testing 100 people was 80% screened positive for ADHD, and so you're seeing some of the major challenges of the country around the criminal justice system, around education, around NEETs and young people's employment, and the intervention on ADHD being potentially one of the most significant interventions we could get. And instead, we're just being told, oh, you just go get a assessment and live a life of like on benefits and give up on life. And all the conversations I have with people, I genuinely can't think of one where it's been different, is like, I have ADHD and it's been a struggle and I want to change my life and I want to go for the positive through the assessment process. Let's talk about waiting times. What do you think about them?
I mean, waiting times shouldn't be happening. I mean, I say that slightly glibly. I know that they are there. So the NHS has not been able to train enough people to be able to diagnose and treat.
I think it's important to say the NHS, because within Right to Choose, we have seen the ability to scale and to train, and the NHS and the behemoth that it is does not have that kind of flexibility.
No, that's absolutely true. I have been. I mean, I don't want to shout too much about Care ADHD because I'm obviously biased. But the team have done a fantastic job of scaling up, exactly as you say. I mean,
Yeah.
my job is not actually to get them to scale up. My job is to hold them to account on those two key issues. I want it to be highest quality we can get, and I want it to be outstanding. And the second thing is I want it to be the lowest possible cost. But they have scaled up in a way I've never seen. I mean, it's extraordinarily, brilliantly done, training people, bringing people through, getting the right governance processes in place at the same time. I've been deeply impressed.
I have to probably I do say I have seen it in some other right to choose providers and some not, to be very clear. We've had some awful examples where wait times have become catastrophically long, and real mismanagement of waiting. But I think that ability for the private sector in supporting the NHS to scale up is clearly fundamentally different, and it's something the NHS should be using. I think that obviously have been teething problems with all, and I think people have been pretty honest about those. But it's nothing to do with the quality of the assessment service itself. It
is true in large parts of the country that the waiting times for the NHS are so long that it means no one's really bothering. Yeah.
Let's talk about Sheffield. I laugh. Why am I? You have some links with Sheffield. Like, what's going on there? Like, last figures we saw for people is the BBC figures. We were in a sort of background, providing some support and advice there. In particular, we were saying to the BBC, you must not accept the answer of when you ask how long do people wait. Do not accept the answer of we're currently seeing people who were seen in X, because it hides a lie. It's a lie of omission, in my view, because it hides how many people are waiting, how big the service is. And if the quantity of people have increased, then you might be saying, oh, last saw we're seeing people who were put on our list in 2023, December 20. You assume 2 years, but actually double the number have joined, or the service is halved. And in fact, it's twice as long. And so we said to them very clearly, you should get the number of people waiting, and you find out the throughput, number of people were seen in the last year. And for Sheffield, that was over 6,000 people waiting and 3 assessments. So an effective wait time of over 2,000 years.
I mean, as you know, well, first off, I was born in Sheffield, and I've lived in Sheffield for all bar 10 years of my life when my parents moved us down south. But I came back to medical school and I trained here. And I've worked in mental health services in Sheffield for 41 years now. It wouldn't really be fair for me to comment on Sheffield directly.
Too tempting.
But let me say the general case. I know that when you have long waiting lists, it's almost impossible to fathom the real need in an area because people don't bother coming forward. If they know that it's 4 years.
I hear you on that. I would push back, partly because I thought about doing a ranking, and worked out the maths, which is like, you've got a population, you've got an age estimate, which is quite easily available. You can do some pretty simple maths on roughly how many ADHD are likely to be there. And you can work out, and you've got the medication numbers per area, so you can work out roughly, take a ratio assumption, and you can go, you've got this many people you've not seen, as well as your queue. So there are some things you can do.
Henry, I entirely agree with you. I think my point was that you can't use the waiting list as evidence of unmet need. It's going to be
because you've got, and we've seen that in areas. You've got shadow, someone described it as a shadow waiting list where people are just put off. We've seen that amongst in some areas, like where GPs make it very hard to get put on the list. We've got triaging now in some areas which create multiple lists, so it becomes hard to get clarity. I have to say, NHS England I know they're in their last throes, but actually you've done some quite good work on creating data points so that can be seen more clearly. It's, I have to say, slightly boggled my mind that those things didn't exist before. I think that shows us my lack of understanding of those kind of big systems that have evolved. So we're seeing new providers emerge, Care ADHD being an example of that, supported by Right to Choose. What's happening?
I mean, okay, again, this is caveated by the fact that I'm chair of Care ADHD. I think that since Care ADHD arrived, which is now, it was April 2024, I think it's been a very positive influence on the service. I'm aware that some other companies, private companies, are following our example of enhancing quality, but some are not. And
Yeah,
I genuinely worry about that. I think that I also think that
it's something that we struggle with, which is, and I think it's particularly hard in this country, which is there's a sort of understanding that you have to say everyone's perfect in the medical world, and trying to show the differences is very, very hard because it's either meets the medical standard or doesn't. Yeah, maybe a conversation for another time. So we definitely would like to help steer people. If we put reviews on the site, which people have recommended, suggested, they'd just get manipulated. They wouldn't have the volume to be reliable. Okay, back to waiting times and
yeah.
So what are we seeing happen in Right to Choose now? What is Care ADHD seeing happen?
Okay, so my understanding of Right to Choose, which is, I'm not a lawyer, I'm not a, sort of, it's basically that if somebody has a health problem of any kind, that they can go to their local NHS, and if their local NHS says we can't see you for well over 18 weeks, which is the standard that they should be seen with.
I think the 18 weeks, which we're going to go to, is different from Right to Choose. So Right to Choose is the ability to choose where you go. And to quote a commissioner, he said it's the National Health Service, not the Regional Health Service. And it was put in place, some legislation put in place to say, you as a person within the NHS and this NHS England, if you don't want to be seen locally, you can choose to be seen elsewhere. It's your NHS. You're living in Brighton, want to be seen in Sheffield, or vice versa, then that is your right, and that's right. That's right to choose. 18-week is different.
I think given that it's the ICB that has to put up the money for healthcare, if there was a local place which had which you could be seen and treated relatively easily, they would probably be unwilling to fund anything outside of the area. But they have
and it's unlikely people would want to.
I think they have an obligation to do it if someone can't get the service locally. And my understanding is that we now have a lot of people who recognise that they probably have got ADHD.
And
well,
we had the task force showed a wait, and this is only on the NHS lists of around 500,000.
Yeah.
Then there are additional people waiting with Right to Choose providers. So it's a higher number than that.
So if you had that in any physical health problem, and there was no or very little service, or a service, as in some places you're waiting 2, 3, 4 years for being seen, then obviously you should have that right to go and get assessed and treated elsewhere where they can do it. And if that's in the private sector, then so be it. And that should apply for people with any condition. Now, I do understand that some ICBs want to cap that, but obviously that isn't it's not acceptable unless they're to do that across the board on everything. I entirely understand that if an ICB said we've run out of money, we're actually going to have to cap healthcare, then okay, that's a matter between them and central government, but they can't do it selectively. They can't say, oh, we're going to cap ADHD, but we're going to carry on with heart transplants.
Why can't they do that?
Because it discriminates against people because of their diagnosis. It's wrong to say we're not treating people with a mental health problem, but we are treating people with a physical health problem.
But doesn't healthcare just make those choices anyway? Isn't that what commissioners isn't that what commissioners and ICBs do anyway? Which is like, go, we're going to fund this and more, and that one less.
Okay, so an ICB's job is really to know what the needs are of their local population, and then to match their provision of healthcare according to that need. So if they're doing their job right, if they have an awful lot of unmet need around ADHD, they need to rejig their provision of services so they can meet those needs. Now, obviously, they can't do that if they don't have the staff to do it. And that's where right to choose comes in.
Yeah. And very importantly, the 18-week promise of the NHS. So right to choose is the right to be seen in any part of the NHS. The 18-week promise of the NHS is probably a level above that in terms of surety. What are you able to tell us about that?
Just not quite sure what you're asking, Henry.
So the current wait list that the Labour government are focused on is people who have the promise of being seen within 18 weeks on the NHS.
Yeah.
And ADHD has been excluded from that. So the targets, the number that when the government says we've got X amount of people waiting, we're not included. And as such, we're deprioritised for dealing with the wait lists around ADHD. However, if you are and do have the 18-week promise within the NHS, which is for consultant-led work, then the right to choose rests with you to use your right. If you're not being seen within 18 weeks of something that should be seen within 18 weeks, the ICB actually has to offer you alternatives if they exist. And at the moment, we're seeing reductions being put in place for our individual activity plans. This would go over that. So are you able to talk to us around individual activity plans, around the wait times?
All I can say is that I personally believe it's wrong to pick ADHD or autism and say we're not going to do it for them, but we are going to do it for everyone else. I think that's fundamentally morally wrong. I also think it's probably illegal.
Yeah.
And it needs to be contested.
And I think we've seen some legal advice that says that.
I think that's probably true. I'm not an expert on this by any means. It's not really been something I've had to deal with very much.
But it's an extraordinary thing we're seeing, right? You've got an area which is saying we won't see any adults with ADHD over the age of 25. A clear age discrimination.
Fundamentally wrong, in my view.
It is. I obviously completely agree. How important do you think right to choose and choices in the NHS for ADHD?
Well, at the moment, it's very important. It would be less important if the NHS itself got to grips with providing high quality services for ADHD. I don't think they're going to do that anytime soon. As you say, to do this effectively and to scale it up to a national level, I think it would be difficult for the NHS to do that. So right to choose at the moment is probably the best way in which that can be addressed. That unmet need can be addressed.
And ICBs have an obligation, right, to people. If not, people aren't being seen in 18 weeks, have an obligation to create a plan. At least that's my understanding. And I think you've talked about you disagreeing with it, and like in your view, is it a matter of patient safety? Like, why do you think it's so important?
Why is it
do people get a timely ADHD assessment?
For the same reason that they should when they're depressed. I mean, it's there are consequences for the people who have ADHD who go untreated. If it's kids, we're talking about failing at school, losing friendships, often end up being bullied, and by the time they're 16, 17, 18, they're using drugs, they've got high rates of self-harm, they've got increased risks of suicide, they don't get jobs. You sort of think it becomes a conveyor belt in which failure is always around the corner. I mean, interesting. I was talking at the Global Ministerial Summit that I've just come back from, and I was talking to the chap who's effectively the National Clinical Director for mental health in France, and he was saying, that he failed all his exams at school, and he says in retrospect he's now pretty sure that all of that failure is because he had ADHD that was untreated. And you sort of think, with help, he's now risen to the top. He runs a very prestigious department of psychiatry. He's got a big research program, and he's the equivalent of a national clinical director for mental health in Paris. And you sort of think, well, he's a bright guy. He's lucky. He got some help, and things have worked out. But I know that en route, he had to go through a great deal of suffering and failure and the like. Me, I failed all my exams at school. I ended up with 3 O levels.
Wow.
It's
How did you turn that around though?
Well, what I discovered was that I can also, if I get into the right frame of mind, I can hyper focus, and it basically means pressure does it. Now pressure doesn't always do that for people. I'm quite lucky. But it's a bit like I get my own version of methylphenidate or lisdexamfetamine. And it is true that when I hyperfocus, I think my wife would tell you, she can't get through to me. It's just
hard.
Nothing else. There's just that. And I've noticed that in my son as well. That he looked like he was heading for failing all his exams and that kind of stuff. And we got him help, and he turned it around, and it's all worked out incredibly well. He's Yeah, he's done very well, gone to medical school and all this kind of stuff. So with the right help, there is absolutely no doubt that people can turn their lives around. That the longer someone doesn't have that help, the more problems arise. And as I said, with that mother who got onto a phone in, her son would never have learned to read or write or do
Yeah.
well at school if he hadn't had that help at that time.
And yet we have the people saying like, oh, it's an ADHD intervention is, just laughter benefits. Like, whereas like in that case, almost certainly the exact opposite. How have you?
I just want to reiterate there that the medication interventions in ADHD have the best evidence for benefit of any mental health intervention we've got. It's the strongest evidence we have.
Extremely important. How have you dodged the? You talked to me about using pressure to get stuff done. Like, I suppose I've got two questions. Like, how have you dodged the anxiety bullet? So, which is that people use pressure as anxiety, use anxiety to get stuff done, and they live a very anxious life, and that can be catastrophic. And then the other is how do you get the small stuff done?
No, I agree. The small stuff is, yeah, I agree with you. It's the small stuff is always difficult. If it comes to doing six nice guidelines all at the same time, where I'm moving, yeah, so for each one you're ultra focused on just that thing. So I can do that, but then get home and remember to do all the things that you need to do at home. That can be more of a challenge.
You're amazing. It's been wonderful talking to you. Thank you. And I'd say thank you for all you've done for people with ADHD. I'm excited for your work with Care ADHD and what's happening overall in Right to Choose. The accessibility through good price is important, and I think we're going to, as a charity, going to be trying to make a bit more noise about that. We've talked for a long time about listing organisations and price because we're worried about some people finding themselves caught, and that is something we'll do. It's important stuff you've been talking around the right on 18 weeks and what I think we should be doing. It's obviously a conversation that's going to continue. Thank you. And thank you for being a part of our conference after your global summit, coming to our global conference. They're slightly different, but only a little bit.
No, I mean, I think this is probably much, much bigger and got probably a bigger reach, even though mine was a ministerial summit or whatever else, and it sounds very, very important. But I also think, having a conference like this where you've got a huge reach to people out there in different parts of the world, fantastic. And I'm very pleased to have been asked to join you.
Well, I'm thrilled that you said yes, and it's been absolutely wonderful. And it's a delight, and I think just important that people know that there are people in serious positions of power and who are trying to make a difference for ADHD. A lot of the time, particularly now, it feels like a big fight, and knowing that people like you there is a big deal. So thank you.
Thank you.
I have to say goodbye. We're out of time. Tim, thank you very, very much. Have a great rest of your day and evening. Thank you.